good, and simply addressing the minimum amount you need to get yourself through the General Council's requirements is perhaps not the best approach. We don't often do physical courses. We run a few with Laurie, in-person courses I mean. And I was thinking about this earlier on because somebody asked about you being seen by a cranial osteopath when you were in hospital. You were also seen by Isle Lederman, weren't you?
Yes. Yeah.
Isle Lederman is an osteopath who has a master's degree in physiotherapy, and he runs the CPD organisation in London. He does lots and lots of physical in-person courses, and he's a great guy, really great guy. We've had him on the show, and I'd thoroughly recommend you look at what courses he has, and find the ones that suit you. But I always say that when you go on a course, you come away trained very well in that one technique. What we try to do is to give you lots and lots of information to make you best prepared, as I say. And the other thing that we do for our members is that we give you peace of mind, because yes, we're looking after all your CPD records, and we can upload them to the General Council, the General Chiropractic Council, or prepare peer discussion reviews for osteopaths, all that sort of stuff. But I've mentioned several times the number of people who contact us because they've got problems, whether that's a complaint or anything else. And I've got a team of people who their sole job, I mean, I reinforce this at least once a month, their job is to make your life easier. It's not to deliver CPD, that's part of it, it's to make your life easier. If you phone us up and ask us where the best pizza shop in your area is, then they will find out for you. But we don't do that because that'd be wasting their time. But that's our job, is to make your life easier. That's where I think we score. We also got a bloody good deal on insurance, much more flexible than some of the others around. But you can find out lots more from the website. Let's get back to you, Laurie. What else you talk we're running your course over this weekend, and one of the first things you talk about on that is practitioner position, isn't it?
Yeah.
And I think people are astonished when they go away from the course to find out that just little changes in your foot position, head position, hand position can make such a difference.
Yes, definitely. I've done lots of sports. For 20 years I trained in karate, got to a reasonable level, and it's only
you were a black belt.
Yes, only after 3 months I suddenly thought, this is the same as what we're doing. If you're standing facing one way and you turn the other way, you turn your feet, and you suddenly realise lots of people don't think about their feet. If the feet are pointing there, it's one thing, there is something else. And I started introducing this fairly early because most people don't know about this at all. If your feet are right, and then you've got a chance. If your feet are wrong, you can't do the technique. You're struggling with your hands. It's not about the hands, it's everything. It's feet and hands and the lot. Yeah.
We've had a question. I should really address a lot of these questions. Somebody's asked how much extension you put in when you're thrusting a neck. Now, we did a sitting technique there. Yeah. We did that one because, first of all, it's one of my favourites of your technique, because you did it on me in my last week of my osteopathic training, and I can remember sitting in my chair while you were demonstrating in front of the class, and I was thinking, shit, this is not going to... What the was that? And it was just so gentle and so easy, and it went off with a hell of a bang in my particular case, and I'm sure I'm all the better for it. I certainly didn't have a headache. But I don't know where was I going with that? I've forgotten now. I've lost my thread.
Does have that effect.
Yeah, maybe I've got a head injury as well. Yeah, it was the HVC on the neck, wasn't it? And so if you were doing a supine technique on the neck, would you still put in extension? How much is it?
Yes, I do. I tilt in that position. I've got them in rotation, side bending, compression, and a tiny bit of tiny little bit of extension to just get that to focus to the point. If you do it properly, you feel the tension increase under your hand. Right. I don't want it fully extended. That's a big problem, but just sufficient that your hand pressure does it. It's a slight. But if you do that inflection, you can't get the tension right. That tiny bit of extension, that works.
Yeah. Are you aware of, and I guess we're talking about cervical HVC, are you aware of any actual cases where a significant adverse outcome can be properly attributed to a manipulation?
Yes, I was responsible in a few cases for acting in court to defend people. I didn't do the attacking, I did the defence. And they were using massive levers and lots of force, and that's a big problem. And how patients get away with that at all, I don't know.
Yeah. And what were the outcomes that we were talking about there? Just increased pain, or
Yes, increased pain because of the position, and they blame the osteopath. And we usually won, but not always.
the one that sticks in my mind is it's not really a practitioner problem, but there was a chiropractor in York who was accused of having killed a patient with a neck manipulation.
It has.
Well, I don't think she did at all, but the Daily Mail decided that she had, and encouraged the family to make complaints. And it's a risk that we've really got to take into account, isn't it? And as I've said before, if we don't record exactly what we do in our notes, then we can be in real danger. And I think she did. And yes, she had an elderly patient, and yes, that patient subsequently died. But she was exonerated by the Director of Public Prosecutions and the General Chiropractic Council until the Daily Mail revved it up, and then it went back to both of those organisations, and she was exonerated again. But in the meantime, the press coverage was abysmal. It was absolutely abysmal. And again, I can only sympathise with the poor woman, because I genuinely don't think she did anything wrong. We had a question from Kim, one of our very regular questions. She says, would you do that sitting OA technique on a 7-year-old child?
No.
Right. Why not?
Because unless they've had major trauma, you can do that with gentle work. It's using quite a bit of force, and you can position it and gently move it, but I'm not going to do that on a 7-year-old. A 10-year-old maybe, 10 or 12, but 7 is a bit young for that.
Right, okay. There's obviously no firm cut-off points in your mind. Would you make that decision based on what you saw in front of you again? Or?
People apply thrust to 18-month-old kids, and I think that's great. If you x-ray them, there's no bones there. That's crazy. They've got all cartilage, and I think that's looking for problems. Unless they've had a fall and they've smacked it, and that could be the reason, but normally I don't know.
Would you be worried about end plates or anything like that in thrusting very young children? Or are you likely to do damage there?
I think you can. Yeah.
Okay. Redkev again says, what are your thoughts on the patients who present with a lateral shift through their lumbar or thoracic spine in relation to the pelvis? Firstly, it's always men, hardly ever women. What's your experience with this? Also, I feel I can't HVT them as much as I feel I should. Listening to you, maybe I should. I think Redkev should come on one of your courses. That's what I think.
That sounds to me like they've got a disc where the centre of the disc is moved slightly to one side, or it's a bit degenerate, and it's shifting them to one side. And you've got to be cautious with those, because my sister had that. And if you wind them up, the disc is ready to go. So that is simple, minimal leverage, lots of compression, minimal rotation, not pulling the shoulder through at all. That's looking for big problems. If you can do that, get them in position, a tiny thrust without increasing rotation is fine. Anything more than that, you've got to be a bit cautious.
Yeah. Victoria says, do you usually do one adjustment to an area or multiple levels? A bit like an SAT approach.
I've tried both. One often won't do the trick. And if I can't get to the right place for that particular segment, I'll look at another part of the spine and then come back. Upper dorsals are so important. If they can't turn the neck, you pull the upper dorsals out and the neck immediately goes right round. So I look at adjacent areas where it comes from and then go back to it. And often if you're just doing the neck, you're not going to relieve it. Relieve the upper dorsals and it's all gone.
I've seen you do that on courses where you've done your tapping technique down the spine. You say, well, this is what you think is the primary lesion. As you say, you thrust that particular joint and then all of a sudden the neck moves. But would you then still consider adjusting, thrusting the neck?
If it needs it, yes. But often it doesn't. But if it needs it, yes. I'm not bothered about thrusting because I'm not using a lot of force, and the patient very rarely screams out unless they're not used to it. There's no problem.
Right. Oh, this is I'm going to enjoy your answer to this question. Pip wants to know how you can explain physiologically the changes that happen in that hip technique.
I don't know. I know it works, but how it works, I don't know. And everybody is better. I've not had one patient, if the hip is tight and as soon as you do that, they're better.
Yeah.
And the same in the shoulder. You can hold it up and tap that and you get the same thing.
Yeah. And we've demonstrated that on so many courses.
Yeah.
We've done it on one online show before as well. And so many people have come back in afterwards and said, it's just amazing.
I know.
Yeah.
I don't know how it works. I know it does.
Yeah.
So I'm quite happy to use it.
Keith wants to know if you always load the vectors in the same order. Is there a benefit to that, or articulate into a bite point as the tissues respond to tension in any order particularly?
No, I tend to use the same order in the neck. Some rotation, a little side bending, compression, side shifting. I'm doing that more or less, but I can change that around. That's just the order I've got used to. I put a bit of rotation, that's the direction I'm going in, looking at that while I'm moving that, while I'm side bending and compression till that gets tight, then I know I'm there. I'm always moving a little into the primary direction. Lumbar spine, a little bit of rotation, compress, rotate, flex, rotate, and constantly looking for that point of tension. Yeah.
Yeah. It'd be fascinating, wouldn't it, to get some feedback from current students.
Yeah.
No pressure.
Yeah.
To just find out, how what you say chimes with what they're being taught and how they're. And in your early stages of training, it's very hard to employ all the things that you've talked about here.
Yeah.
But certainly in my day, we got a course with you at the end of my after we graduated, effectively, and it wasn't basic training, and yet you've said on so many occasions that you really need to know this stuff because this is the sort of technique, minimal leverage, which is going to keep you out of trouble. Yeah. So, Shocker Stockers says, should those that practice C-spine HVT pay a higher indemnity insurance? That's not a very fair question to ask you, is it?
I think if they're using good technique, there's no more danger of thrusting in the neck than anywhere else. If they're using full levers, that's different. Then there's all sorts of problems.
Because we offer a good deal for insurance to our members, I've had long conversations with the head honcho there at BGI, and first of all, the insurers, they work on the basis of what's the general payout for things that have gone wrong. But when you talk to the GOSC or the GCC, actually most of the complaints aren't about HVTs. They're about communication and consent.
Yeah.
If you discard all those ones which are just blatant, irresponsible, immoral practice or whatever, it's communicating well with the patients. Most patients coming to us expect to get an HVT, don't they? Yeah. So, what have we got on these ones here? Holly says, I've always found that as a woman, HVTs are generally easier to perform. If you're a man, as I wouldn't feel comfortable squeezing a patient's head onto my chest, similar to other HVT positions. Right, sorry, she says that as a woman, she thinks HVTs are easier for men.
I think that's true. And with that one, you can take a pillow, put it on your chest and compress the head through the pillow. That's just as useful as doing it without. You still get the same tension without the problem with the boobs in the way. Yeah.
Yeah. And I guess, we're always worried about crossing any sort of lines with patients or vice versa.
Yeah.
And I sympathise with women as well, because there are some patients who will immediately start to make inappropriate comments if they're being hugged by a woman or being closely gripped by a woman, I guess. Yeah. Claire says, one of our regulars has joined late and asked in the chat what she'd missed. The replies amounted to bum smacking and the secrets of osteopathy, and that sums up this evening. Sarah says she used to love doing the two-person techniques in the clinic, leg pulling or arm pulling to get some traction. Not sure why we don't do more of them. I guess it's time and cost effectiveness, she says. And also, a lot of people work on their own, don't they?
Yes. Yeah.
Did you actually, you said earlier, did you always work in practice with others, or did you work on your own?
No, I started by myself, and then when it got busy, I had a receptionist, and then an assistant, and so on. So there was all that from 3 years onwards. Always had assistants with me.
I don't know if I'm getting a little bit sort of jaded, a little bit overly worried in my old age, but having listened to so many complaints and situations that people have put to us through the our help line, as it were, I do worry, particularly again for female patients working on their own, because it's a very vulnerable position to be in. I think men are equally vulnerable in terms of the fact that if it's not in their notes, then you could be laying yourself open to complaints if somebody wants to make that complaint about you. I'm sure I had another one. Redkev thanks you for answering that question on lateral shift. Says he's always assumed this is down to a disc and he'd love... Oh gosh, where's that gone? Something's gone wrong here. Excuse me, this sometimes happens. He'd love to know if you've seen this presentation in women, because you've only seen it in men. That's that side shift.
Yes, I have in a few cases.
Yeah. So not unique.
But certainly more in men, yeah.
Yeah. What's the... If you had to give up everything but one, what's your favourite? What do you think is your most useful technique?
I think the lumbar roll. More people I've eased with that hundreds of thousands of times, but
Yeah.
I still don't know what's going to happen when I'm winding it up, whether it's
Yeah.
going to go or not.
Okay. I've got somebody whispering in my ear, but I can't hear a word they're saying, so excuse me if I seem a little bit distracted there. You're going to have to speak up. Okay, so we've got a question from the audience. Am I right in thinking we've got a question in the audience there? Oh, right, a man in the spotlight. There we go.
Right. Hi both, thanks for coming. Laurie, what do you think of SIJ HVTs?
When I was a student, I learned all the different positions. One person says they go up and down, another person says they go forwards and backwards, and I tried thrusting it forwards, tried thrusting it backwards. I think with side-lying or other techniques, if you can get the leverage right and you get the force accurately applied, and you can get that to hit the SI joint accurately, you sort it out. And I'm not worried about position. I used to be, but not now.
So you think there's a use for them?
Yes.
Okay.
Yeah.
Thank you for being brave enough to stand in the spotlight, because you're putting all this lot to shame, because they're...
Shall we do it in a sec?
Yeah.
Yeah, okay.
I was just wondering, during sort of spinal manipulations, if somebody is coming in either with like confirmed or suspected like end plate modic changes, with the active inflammatory response, is that enough for you to think twice about it, or how would you approach a patient that has a lot of pain due to like stage 1 modic changes?
If they've got modic changes, they can still get mechanical dysfunction in the joint. If you sort out the mechanics, then the patient's better. They come back, oh, that's better, and immediately it is better. But once again, I'd use minimal leverage. In the thoracic spine, what do you use? Hand underneath, compress, rotate, side bend, side glide, flexion. I'd use all of that, and the thrust then is a tiny movement. It's not a big whack. And you can ease it without any strain or anything. If in the position of winding it, it's hurting, I'd stop.
Yeah.
Yeah.
So because you're doing a very minimal leverage, you're not sort of at risk of increasing an inflammatory response
No.
due to a quick movement?
No. You will get reaction, because once you open the joint, it does blow up a bit, but it's minimal. They come back and say, oh, it's a bit sore, nothing special, even though the thing is released. Yeah.
What is also worth bearing in mind, perhaps, Laurie, is that how many patients have come to you? You have no idea if they've got modic changes, because if they've got an MRI, then you're almost certainly not going to know about that.
No.
And you would almost certainly have gone ahead and done your normal technique in complete ignorance of the fact that there's the modic changes are there.
Yeah.
There's a couple more coming in here as I'm seeing. Jonathan wanted to ask whether you would say older age is a contraindication to HVT.
It certainly is a contraindication to normal HVT. Past 70, you can't thrust because you can't get the joint to go. So you're using mobilizing, muscle energy, that sort of thing. But if they've got something that's stuck and you can position it and get it right, a minimal leverage is often possible. And age is not the barrier. People trying to thrust my back, they can't do it because it's too tight over the years. But in most people, you can get some sort of leverage, and if you're playing with it very gently, and often you just get the right position, and it just releases.
Yeah. How many different techniques for the SIJ do you teach on the course that we're running this weekend?
I don't know. Side lying, prone, standing is the best one.
Right.
That's a very old-fashioned technique from Wernham taught that years ago.
Yeah.
That's a nice one.
And I asked the question because I know what techniques you're going to teach at the weekend. But, there are so many approaches to that same joint, aren't there? And some of them are pretty simple approaches as well, which are minimally worrying for the patient, if I can put it that way. We've got another question from the audience. I don't know who that one is. Over there.
Hi, Laurie. This is one really regarding your karate as well.
Yeah.
Another leverage. Are you applying kime when you're doing that? Do you think that you're using that as a part of another leverage?
Yes.
What is that?
It's the tensing of the whole body at the same time,
Right.
to get that force. And I just feel that Laurie uses that when he's doing the technique. It's not just about using body levers, it's actually that kime technique as well.
So do you think we should add 7 years to the osteopathic degree so everyone can get a black belt in karate? And
Absolutely.
yeah, of course. Yeah. Do you think that's something that people can master, Laurie?
I think you do. If in the old BSO, which was a long time ago, the principal was sometimes working in their clinic, and you could hear him. It came up not quite to the roof, and you could hear him. And every say,